Dr. Lim, I am so excited to have you here and have you share your book, Breathe, Sleep, Thrive. It is amazing, and I really think it's going to help so many people. And I just want to talk a little bit about why you wrote the book and what you would like parents to know. I am very excited with how you layered this book. And so I'd like to start out with a little bit of your background and why you wrote the book.
Great. No, thanks for having me, Sheree. I really appreciate this opportunity. Why I wrote the book is I basically got involved in gentle sleep medicine about 12 years ago. It was prompted by my husband snoring, really frustrating. And so I decided that I was going to learn more on how to help manage it with dental appliances so that I could help other spouses that were in the same frustrating situation. And so that's when I enrolled in a graduate diploma in dental sleep medicine. I became able to accept referrals from sleep physicians to manage this problem. And I started to notice these patients, it's not just snoring. A lot of them have significant health conditions and poor quality of life with unrefreshing sleep, brain fog, depression, anxiety. And really, we are treating a craniofacial problem. It's a problem of poor jaw development. And people have suffered for decades, and we've missed that opportunity to grow the jaws properly in the first place. So that's why I wanted to write this book, to help parents understand that these problems they have their developmental origins from infancy. And if we know what to look for, we can actually make a difference and alter that trajectory of development.
And I think that that's amazing. And I'm glad that you start with that, because in the dental hygiene world, in the dental field, we tell parents to wait until they lose all their baby teeth to see an orthodontist when they're 7 or 8. But we've missed that growth potential when we do that. So can you tell us a little bit about when you think parents should start looking at this and when to assess it?
Yeah, so the traditional age for early interceptive orthodontics is around age 7 to 8 years. And when I was doing my dental sleep medicine course, I found research to support that palate expansion could improve breathing and sleep apnea. And in practice, we know that when we refer patients for early interceptive orthodontics around the age of 8 years, quite often, even then, the approach is to just watch and wait. Just wait till the child is 12 years old. Their growth is 90% complete. We're going to get a more predictable outcome and more efficiently. And sometimes we have to take out teeth to alleviate dental crowding. However, we haven't really been able to address the underlying jaw problem. And 7 to 8 years, when I met Dr. Christian Guilleminault, one of the pioneers of sleep medicine in 2014, I was telling him how his work had really inspired me to learn more about early interceptive orthodontics so I could offer it to children in my practice. And he said to me, if you're doing palate expansion, you're too late. So I really didn't know what that meant at that time. But I now understand that what he's trying to say is that sleep apnea, it's really like a jaw problem. And the jaws form the framework for our collapsible upper airway. And if they're not formed properly, we're going to have a deficiency in our breathing or our airway support. And the jaws are growing most early in the 0 to 6 years of life. That's when we have the most significant jaw development. 60% of the adult-sized jaw is attained in those first 6 years. So that's really the time that we need to be looking out for problems. And when we have poor jaw development, it's really a reflection of poor muscle function. So the way that the mouth is working, and the tongue in particular has a very important role in sculpting or developing the palate. And so we really need to pay attention to this very early on in life. And in terms of what to look for, and how do we optimize that oral function that provides the stimulus for the jaw development? Starting with breastfeeding. In the first year of life, the most rapid window of jaw development, we want to have optimal breastfeeding because that's the one modifiable factor that's most important. And so we need to have good tongue suction with breastfeeding to recognize the mechanical benefits of breastfeeding over bottle feeding, because breastfeeding requires tongue suction, the tongue lifting up to the roof of the mouth, and then as it falls, it creates a vacuum, and that's how milk is transferred efficiently. And so we want to make sure that we have really good breastfeeding and looking out for compensations such as, pain or weight or overuse of the lips and cheeks, whether there's any reflux-like symptoms which could reflect poor swallowing and suboptimal feeding and poor use of the tongue. What else to look for? So breastfeeding is really important to look for. Then we want to minimize pacifier use and nasal breathing as well. So it's really the light, persistent forces that take place over the whole day. So with nasal breathing, we have the mouth closed, we have the tongue suction to the roof of the mouth, and that provides the proper stimulus for jaw development. So if the mouth is hanging open, the tongue is more likely to sit low, and we're not going to get the stimulus. So really, overall, what I really want people to recognize is it's the oral function, the way that the muscles rest and function, that actually determines the jaw growth. And we can look at this very, very early on. And when we have problems with muscle function, such as speech problems or difficulties chewing and swallowing, they're all signs of the muscles not working well, and they're not going to be providing the proper stimulus for the jaws to grow well.
So we really should be looking at it in infancy and how we're feeding. So what should they look for if they're not able to nurse?
Yeah, if people aren't able to nurse, well, one of the very first things we want to rule out is tongue tie, obviously, which restricts normal tongue elevation. It's a very hidden and underdiagnosed problem that can contribute to feeding issues. So it's always good to get that checked out for. And if parents miss that opportunity to do breastfeeding, to really recognize there are many other opportunities along the way, as long as we recognize that when we use the bottle, we start introducing compensations, the tongue and the other muscles don't work as well. So there are many opportunities to get that back on track early on in life.
Yes. And so that brings us to the next thing. So if we haven't looked at that, or we weren't taught that and we didn't know that, what do we do to get that back on track once we've noticed that our kids are having some of these open mouth posture, weakness in the muscles and mouth breathing and not able to nasal breathe? What do you recommend they do then to get back on track?
Yeah. So the next opportunity really is about at age 6 months. Chewing. Chewing is really great, especially for our lower jaw development and to build the tone of all our jaw muscles. And so I really am a big advocate for the use of Myo Munchee, or the Myo Munchee for babies, because what that does, it actually helps provide that increased sensory input that babies need, plus that functional stimulus of the jaw. So getting them to chew, and they're building their lip seal, promoting nasal breathing and proper swallowing. So deactivating some of the facial muscles that may have been overworking through the use of the bottle, and just introducing more texture in the foods, not overdoing the purees, because that involves a lot of sucking, and we want to have more chewing and more use of the jaw muscles. Yes, I think chewing is the next most significant thing, and really trying to make sure that children have nasal breathing, having a clear nasal airway. So if there is some congestion, or really doing nasal rinses and keeping the nose clear.
I definitely think that's good. And I think you talk a little bit in your book too about why this is happening more. And that's because we used to be hunter-gatherers, and we had different food, and now the foods are a lot softer. So, we're mashing them and sucking more than chewing. So I think that is a wonderful answer. So then what happens later? Let's say now your child is older and they've missed that opportunity. What's the next step from there? So what signs do they look for, like bedwetting, dark circles under their eyes, things like that?
The next most common problem is going to be enlarged adenoids and tonsils. Around the age of 2 to 3 years, they really peak in size, and this can cause disruptive sleep and breathing. So the symptoms that you described are symptoms of poor sleep and breathing, and looking out for snoring or any sounds that a child makes with their breathing. We want breathing to be quiet and breathing to sleep to be still. And so any restlessness, tossing and turning, any unusual sleep positions like neck hyperextension and stomach sleeping, which could be compensations to improve the airway if a child has airway restriction. Teeth grinding, bedwetting, unexplained awakenings. Some of these children that come into mum or dad's room in the middle of the night because they don't want to be on their own. Those are the other type of symptoms that we look out for that could indicate that the child is not breathing well.
And then do you recommend that parents videotape their kids at night when they sleep? Do you recommend sleep studies?
In relation to the video, I think it's always helpful when parents have concerns or they notice unusual things like a lot of tossing and turning or gasping or snoring to record a video, because that's how you can get taken more seriously and have your concerns validated. But in terms of sleep studies, it's not something that I refer to regularly for many of my patients that are having these sleep disruptions. The problem with sleep studies is that they are very focused on obstructive sleep apnea or the more severe breathing disruptions. To get counted as obstructive sleep apnea, you have to have, as a child, a minimum of one apnea or hypopnea per hour of sleep. And so that's a 10-second pause or restriction in airflow to get counted as obstructive sleep apnea every hour. If that's 9 seconds, or if it's 8 seconds, it's not counted. And a lot of the time, when you get a sleep study report, they won't recognize that a child only needs to have one of these events per hour to get counted as obstructive sleep apnea. For an adult, they need to have 5 of these events per hour to get diagnosed, but children, they only need 1. And sometimes they use adult criteria or adult measurements, and we miss a lot of children. They get told there's no problems or no obstructive sleep apnea, but that's really not what we're looking for, because if there's more subtle breathing disturbances where their sympathetic nervous system is on high alert and they're really responsive to any restriction in airflow, they will actually have an arousal from sleep and maybe even grind their teeth to keep their airway open. And so they won't have these 10-second apneas or hypopneas. And what is still happening is they're having very disturbed sleep, and it can affect their daytime function and is increased risk of behavioral and learning problems. So with children, I think it is better if we can address the snoring or those symptoms rather than the numbers itself, because even snoring has been linked to so many problems in terms of ADHD symptoms, poor attention, concentration, and socio-emotional problems with these children that are having poor emotional regulation or tantrums, meltdowns, and it really affects their learning, with, research showing that even snoring can alter the brain function or the brain structure. We really need to address that. So sleep studies, I think, can underscore the severity of the problems if we're looking at those final results and numbers. And if I have a child that is having symptoms, I want to address the risk factors. I don't need to have a sleep study. And a lot of ENT surgeons are the same. If there's enlarged adenoids and tonsils, child is snoring, they're having difficult behaviors, we don't need to have a sleep study necessarily.
And then you also mentioned the ADHD and that behavior. So I think that's another thing to segue into that before we put our kids on medications if they're being diagnosed with ADHD. What do you recommend in that case?
There hasn't been much research specifically about the reduction in ADHD symptoms, but it is actually something that I see in practice all the time. When we can get a child better sleep, they are going to function better and their behavior is going to be easier to manage.
That's why I love your book, because it explains everything that I couldn't put into words and I didn't know back then. So that's why I started the Healthy Mouth Movement podcast, is because it was a way to reach parents and get this information. I've been a dental hygienist for over 30 years, and I didn't know how important your tongue was until my daughter started having issues. So I figure if I'm in the dental field and I didn't know this, how many other people didn't know this? So I am really grateful for doctors like you and people that are in this airway space and sharing this information, because we truly can make a difference and not watch our children suffer like I did. I couldn't explain that for my daughter.
We need to promote more awareness to parents that the ultimate goal is really to restore nasal breathing. And obviously, palate expansion has a really important role in that, because the palate is the floor of the nose. And when it is narrow, expansion is really well supported to expand that nasal floor and improve the nasal airway and improve nasal airflow. But in addition to that, we need to restore the muscles, because a child who has been chronically mouth breathing will have changes in the way that their muscles work to compensate for that obstructive breathing and the open mouth posture and the flaccid lips and the flaccid jaws. And we've got to really work together to get the muscles working well. And that's where myofunctional therapy comes through, to get the muscles working well and get the tongue working well, because tongue is the most important upper airway dilator muscle, or the genioglossus that forms the bulk of the tongue. And that means it helps to keep the airway open during sleep. And so we need to get that working well. And myofunctional therapy also has a really important role in addressing the underlying dysfunctions that created poor jaw development. So it's really important to address those to get stability of the results of any orthodontic treatment we do. Many of these issues have their roots in myofunctional disorders. And so myofunctional therapy fills a really important void for those breathing concerns and the orthodontic instability and many other issues. The other thing that I want to let patients know is that when we do this palate expansion, we also need to address the underlying dysfunction. It needs to be combined with myofunctional therapy to get things working better. And if there is a tongue tie, that needs to be addressed to get the muscles working better, because we need that tongue lightly suctioned to the roof of the mouth. It's that tongue that is the best orthodontic retainer, because it provides support against the inward pressures of the lips and cheeks. We need to make sure that's done. Otherwise, I cannot guarantee how stable those results are. And that is compliance-based. But in principle, the more we can grow the jaws, the better space we have for the teeth to come through. So yes, I do think many children will be able to avoid orthodontic treatment or braces, but it's not something that I necessarily guarantee upfront, and I'm pretty clear about that.
Thank you for answering that question. Then I had one more question that parent had asked before we started talking today. What if they don't want to do myofunctional therapy they have a tongue tie, let's say, and we recommend myofunctional therapy with the release. And I've had several parents just want to go straight to the release and not do the therapy. Why do we recommend the therapy? And what can happen if they don't do the myofunctional therapy along with the release?
So my ultimate goal always is to get the tongue lightly suctioned to the roof of the mouth. It's the best for breathing and orthodontic stability. And if we don't get that tongue, if we don't do the therapy, the tongue is never going to be able to do that, because when there is a tongue tie, we introduce compensations and overuse other muscles, and the tongue doesn't actually ever get used. And it doesn't develop that tone or coordination necessarily. And so doing a tongue tie release without it may not necessarily change anything. And that means that we're going to have increased risk of reattachment or scarring, because the tongue isn't going to adopt new ways of doing things, patterns. And so reattachment is basically normal healing when the edges of a wound want to join back together again. And so if we don't change muscle patterns, we're not going to get good healing. We're going to get more scarring and reattachment, and nothing will change. So it becomes really pointless. I try not to rush into tongue tie release. Usually when I have a child, I will probably do palate expansion first, because I think that helps restore the proper space for the tongue to fit well. And I think it's often the most significant intervention out of palate expansion and tongue tie release to improve sleep and breathing. So I want to get that quick gain, and that buys us more time to be able to work with the therapy and do the tongue tie release.
And there's so much more in your book that just touched on a little bit as far as like the process of what to look for from the beginning all the way up until when they may need an orthodontic evaluation, because traditional orthodontics straighten the teeth. And you're looking at much more than that. And I think that this is the wave of the future. And your book, like I said, it's not only good for parents, it's good for professionals that get a better picture as far as how you put everything together in this book. I love that. So what else would you recommend for parents?
I think we want to let parents know that if there are any speech concerns or any sort of other myofunctional disorders, really it's a sign that the muscles aren't working well. And if they're not working well for speech or for chewing, that means they're not going to be working well for sleep as well. And all those muscles of the tongue and the throat, they have a really important role in keeping the airway open during sleep. And so we need to get that working as well. So I'll see many children that have speech problems. They come in for a tongue tie consultation, but really we can actually start to hear that they're having significant problems during sleep and with their daytime function. And so all these things really go hand in hand. We mustn't treat things in isolation. So it's not just a speech problem or a picky eating problem or a breastfeeding problem. It's really how the muscles are working for sleep and how they're going to affect the way that the jaws grow. And so we really need greater integration between professions and really trying to optimize those functions. When we see breastfeeding, it's not just about no pain, good weight gain. It's really about making sure those muscles work early on. And so really recognizing that everyone has their role in the bigger picture, and it's not just little compartments that we're working in.
It's putting it all together and connecting the dots. And I think that that's where healthcare right now is kind of failing us a little bit because we treat symptoms. So a lot of times, especially parents, wait until there's a problem rather than looking to intervene early on. So that's one of the things that you talk about in the book. I think you lead the book with, when you find out you're a parent, you read a lot of the handbooks and get as much information as possible, but there's so much that's missing. And your book is part of connecting the dots of what we are missing when we start out, because I think we're not looking at that. We don't look at the root cause. We don't look at prevention. And if we can get that information out to not wait until you have these symptoms, but when you do have these symptoms, kind of know what to look for. And it starts early.
I think we need to help people understand that these adult problems, we really have this window of childhood to intervene. And we want to try to address it early because it's really hard to connect those dots, hence the book. Yeah. But at the same time, I am seeing a few parents where they're bringing in their children as toddlers, are concerned about the mouth breathing, and it can be very difficult age. I think there is that age of, apart from optimizing breastfeeding, 0 to 3, that's really difficult, really challenging. I think it can create a lot of anxiety for parents if they can't find the right professionals to deal with these problems. And so I think it's really important to recognize that we still have a window. If we can identify it really early, it's never going to be one quick fix. It's all about how can we optimize the way that the muscles are working? How can we optimize the way that the jaws are working? And over that period of time, even if we get in before 6, it's still quite a good age to get in. And I think in the future, what I'd really love to see is for parents to have almost a library of things that they can do with their children to stimulate better muscle function. I mean, too often parents are told that their child will outgrow those problems. They grow into new problems. I think modern healthcare is really focused on medicating, and even things like depression. It's such a common issue. And one of my colleagues here in Perth did a fantastic study looking at adults with obstructive sleep apnea and seeing the high prevalence of depressive symptoms. And after treatment of the OSA, there was barely any people that had clinical depression. And in that study, 41 people had suicidal thoughts. And after treatment, none of them had it. And so we need to get away from medicating and get to the bottom of these issues and making sure that we can investigate poor sleep and really understanding that airway health is a really key pillar of health. And it's important as diet or exercise, and it's really commonly overlooked. So we need to get more and more people on board with the importance of healthy breathing and breathing through our nose and good jaw and airway development from infancy.
Absolutely. And I think that's a good way to wrap up. Is there anything else that you would like to add?
Yeah, exactly that. And recognizing that we need an integrative approach. And so when we're coming to nasal breathing, just as important as looking at an ENT to remove any obstructions from our nose and throat, we really need to pay attention to the jaws that form the outer framework for the airway. the floor of the nose, the housing for the tongue, and that support for that collapsible upper airway. And so really understanding the role of orthodontics and making sure that we address the poor muscle stimulus for jaw development as early as possible. So addressing these myofunctional disorders and getting the mouth working well as early as we can.
I agree. Thank you so much. And thank you for sharing this. Thank you for writing the book.
Thanks very much for having me on and for all you're doing to really promote and connect dots for people as well.
Thank you so much. I appreciate it.